all for attending. It's a beautiful night here in Minnesota, so it's kind of tough to sacrifice a warm summer night to do some orthodontics, but hopefully it'll be worth your while. If you have any questions regarding my presentation or anything that comes up that you think of after the presentation, you can email me or call me, and my phone number and email address are listed on the screen right now. So feel free to ask any questions at any time. I'll be happy to answer them as best as I can. Um, when we start talking about early treatment, the first thing that must be done is an airway evaluation. And I'm not going to go into great detail about airway evaluation, except that you can do a cursory evaluation by looking at the cephalometric x-ray. And if you have any questions regarding airway, you can do an ENT consult. And the ENT may recommend nothing. He may recommend decongestants. He may recommend radical treatment such as tonsillectomy and adenoidectomy, depending upon the situation. But a patent airway really allows the brackets and wires and appliances that we use to work a little better because muscular function is optimal. And oftentimes with an airway that's not patent, we get less than optimal muscular function, and that can really be a problem. The big thing when we're talking about habits and airway, tongue thrust is a big side effect of a bad airway, and the tongue really affects treatment negatively when its function is not optimal. And there are some basic approaches you can use to really manage tongue issues. And the basic approaches are appliance therapy or myofunctional therapy. And many clinicians do both combined. They will do a combined appliance therapy and myofunctional therapy approach. Considerations regarding tongue position and tongue function is habits or abnormal swallowing patterns may result in detrimental forces to the teeth and dental alveolus. Some patients show very unfavorable dental development, and some patients show less unfavorable dental development when faced with tongue issues, but form always follows function. And treatment will proceed better and more effectively if the tongue function is optimal. And the tongue does have the greatest impact on tooth position, therefore, less than optimal tongue position should receive the highest treatment priority. And you can see open bites, dental protrusions, speech abnormalities, a lot of things related to tongue issues. A quick review, this is probably not news to the great majority of you. The tongue is the scaffold for the development of the upper jaw. When the tongue is functioning optimally, it rests in the roof of the mouth, and that muscular function causes development, results in development of the upper jaw and development of the maxilla, sort of keynotes every other developmental thing that happens as a patient grows. So with a well-developed, properly expanded maxilla, everything else seems to fall into place a whole lot easier. So our job is to identify the problem if there is a tongue problem, assess immediate and long-term effects, and inform the parents regarding the consequences of the habit. Treatment is appropriate if, one, the parents desire treatment. Sometimes parents will not buy into this, but I think with education they will. But the child also has to be ready and mature enough to handle treatment. And for the most part, by the time a kid gets to age 7 or 6, they are ready for this. Fixed appliance therapy. We usually use bands on the E's or the 6s when we make appliances, and they're preferable to removable appliances because, of course, the patient can't take them out and they work 24 hours a day. And you can also design appliances which help modify habits concurrently with arch development, specifically cribs or spurs added to an expander. And many clinicians, again, are using a combination habit appliance combined with myofunctional training. Here's a tongue habit appliance, and notice there are some cribs, spikes. These are kind of brutal. We try not to use these because the kids don't like them very much, but for stubborn habits, they are effective. My favorite appliance for tongue management is the bluegrass. And the bluegrass is named a bluegrass appliance because it was designed at the University of Kentucky, the bluegrass state. And what it is just a piece of acrylic on a bar that is positioned approximately where ideal tongue rest position is. And that piece of acrylic is movable. And so what happens is when the appliance is in place, the tongue tends to want to play with that, and that teaches proper tongue position. How many times have you had a patient that has a cracked filling and they say, "Doc, I can't keep my tongue away from that thing." And so the tongue likes things that are a little bit abnormal and tends to go to them, and the acrylic bead is something that it's not used to, so it tends to play with it, and that gently teaches tongue position. Now, myofunctional therapy can be used in conjunction or separate from habit appliances. Um, you can do it in your own office or by referral to an orofacial myologist, and a detailed explanation is beyond the scope of this presentation. But what I did is I included a sample tongue training program in the course packet. That's article number 1. I find the program to be easy to use and effective and really good for young kids because it's so simple. Now, I think Scott sent you an email if you registered for this webinar, but you can link to the articles referenced in the webinar. There's 7 separate articles. And if you go to the site, these articles are available for download. So if you want to take a screenshot of that to have that, or Scott will send you an email so you have access to the articles. My opinion, a therapist for tongue training or habit cessation seems to work a little better than doing it in the office, especially if the doctor does it, because the patient and family tend to place more value on a separate service rather than something that is thrown in. So if the doctor's doing it, it doesn't seem to be as important. If the therapist is not available, then the myofunctional therapy should be done in-house. And you can consider myofunctional training for one of your team members. And so you could have one of your assistants or hygienists, probably a hygienist, versed in myofunctional training, and he or she could do all of the myofunctional training in your own office. Now, once we get the habits in line and breathing is pretty good, we have to determine the need for arch development. And arch development comes before tooth movement. The most useful measurement for mixed dentition analysis to determine if the maxilla needs arch development is the maxillary transmolar width. And the average for a teenage to adult patient is 35 to 39 millimeters. Dr. McNamara from the University of Michigan has done numerous studies regarding this measurement and has determined that if the transmolar width is 35 to 39 millimeters, it usually is wide enough to accommodate a permanent dentition of average size. And if you want to do a quick measurement, you can just put a cotton roll in between the upper first molars by the lingual grooves. The cotton roll is 37 millimeters wide, so you can get a really good idea of what your transmolar width is just by using a cotton roll. So we measure, and narrow widths, we tend to do arch development. If it's wide enough, we tend to more move teeth. So that's the measurement technique. Facts, the width naturally increases from age 7 to 14 with growth. There is a catch-up. If a person starts with a narrow transmolar width, they tend to increase more than the average and wide during growth. And I think that's probably due to improvement in tongue position as a patient matures. And the quicker we get the tongue up to be resting in the palate, the quicker that it can start affecting upper arch width. So there's the measurement. Adult 36 to 38, mixed dentition 34 to 35 is about average. And Dr. McNamara's studies in 15-year-old young men and young women Non-crowded cases average 36 to 37. Crowded cases average 30 to 31. And you can see the initial 7 to 8 year widths. And so that's maybe mainly what we're going to focus on in this presentation, the cases where the transmolar width is narrow in the 7 to 8-year-old range. There's a constricted maxilla. Now, we also use the Ponce analysis. Now, the Ponce analysis has been proven to be not very scientific based upon how it was originally discovered. Dr. Ponce was a French orthodontist, and he did his study on French teenage boys in the early 1900s. It is just a setup, a measurement to determine the ideal relationship between the size of teeth and ideal arch width. Despite the fact that it is non-scientific, it gives you a really good idea of how much arch development is needed. And it sort of has withstood the test of time, even though a lot of people have tried to bash this thing and say it's not scientific. Well, neither is Steiner cephalometrics, which was done with a sample size of 1. But it gives you a good idea of where you need to go. And now, article number 2 is actually not an article, it's a spreadsheet. And we'll go into how to use that spreadsheet if you have Microsoft Excel. The spreadsheet will do the Ponce analysis for you. So the first thing you do if you want to do a Ponce analysis, determine the patient's facial features, dolicho, meso, or brachycephalic. And this is a picture of the spreadsheet. Everything in gray is what you have to enter. And so you enter the widths of the 4 maxillary incisors and enter the premolar width, distal pit to distal pit of the first premolar. Now, if you're in the dentition, you just use distal pit to distal pit of the D's and mesial pit to mesial pit of the molars, of the first molars. And this calculates it for you. And so in this particular case, the premolar area needed 4.75 millimeters of development. The molar area needed about 5 millimeters of development. So with the spreadsheet, you don't have to remember the proportions. It just calculates it for you. So here's measurements. There's measurements. And again, if we're focusing more on mixed dentition, distal pits of the D's instead of the first premolars, and molar width. So the information needed, 7 measurements will give you the Ponce analysis, and these are the 7: the width of the 4 incisors, the measured premolar value or measured D value, and measured molar value. And then if the patient is brachycephalic, mesocephalic, or dolichocephalic. And there it is again, that's the spreadsheet, and you're certainly, you can download that spreadsheet off of Scott's website, off of the Renstrom website, and use it if you see fit. My feeling with arch development, and this is a general review, it's a general rule, it's not based on any peer-reviewed studies, but in my personal experience, if less than 6 millimeters of arch development is required, it can usually be managed with arch wires alone, and we're going to go into strategies for doing that. If it's greater than 6 millimeters, we usually require some sort of expansion appliance to get there. Why 6 millimeters? The number seems arbitrary. It's 3 millimeters per side, and it is somewhat arbitrary. But if you look at the point of force application compared to the center of resistance of individual teeth with an expansion appliance, and on the right you see a quad helix, compared to brackets on the left, you can see the point of force application with brackets is much farther away from the center of resistance of the particular tooth than the point of force application with an expansion appliance. And so what happens is, when the force application is far away from the center of resistance, you get rotation. If the force is applied away from the center of a body, it will move in the direction of the applied force, but it will also rotate. So we get more rotation, or in other words, tipping of the teeth with arch wires than we do with an expansion appliance. And if you're moving them out about 3 millimeters, so that'd be a total of 6 millimeters of expansion, the tipping doesn't really affect things that much. When you start doing more than that, then the teeth get tipped and you start getting poorer occlusion. And so you need more bodily movement, and you can achieve that with an expander. And there are lots of different expanders that you can use, and we'll get into that in just a few minutes. So upper arch expansion, the appliance of choice is a rapid palatal expander. And its main indication always was molar crossbites. There's a lot of other reasons to use it now. Um, these cause bite opening. As the teeth are tipped and moved, the bite opens. And in strong muscle patients, the muscle forces kind of overpower the extrusive force. So a banded expander is okay. In weak muscle patients, we want to discourage bite opening, so we use a bonded expander. And here are the effects of an RPE. You can see it expands in the anterior more than the posterior, but it's still the method of choice for correcting molar crossbites. And this is orthopedic expansion. So it's changes that occur in the underlying skeletal structures rather than the movement of teeth. And there are many sutures in the skull near the maxilla that rapid palatal expansion affects. And it's not restricted to intermaxillary sutures. So there's sutures all over the place that kind of can get affected by a rapid palatal expansion. So it's not just the palatal suture. The mid-palatal suture is the big effect, though. That is split, and that reheals, so you get bone. So the net effect is an increase in skeletal in orthopedic expansion. It's skeletal, it's not just dental. And if mid-palatal fusion of the suture, if it's the mid-palatal suture is fused, it's less predictable. And then we have to go to some appliances if you're going to do RPE in adults, which is like a MARPE or surgically assisted rapid palatal expansion. But up until about age 15, you're okay, and you can use it without those adjuncts. And there's how the suture matures. And so there's an age limit to why the RPEs are effective only until about age 15. And here's the side effect. And the bite opening effect can be encouraged or discouraged based on appliance design. Here's a banded expander that encourages bite opening. Here's a bonded expander that discourages bite opening. Now, I added to this article list a list of bonding instructions. This is a primer by Dr. Paul Ganji from Reliant Orthodontic Products. It's article number 3. It talks about special situation bonding and bonding technique. Reliant Orthodontic Products is a great company to become affiliated with. Their catalog is much more of an educational tool rather than a sales pitch, and they have really good products at very reasonable prices. So if you want to find out a lot about bonding and maybe improve your bonding technique, you can go over this little primer. And on page 7, there's bonding instructions for a bonded rapid palatal expander. Now, my preferred appliance design is the Haas type rapid palatal expander. It has palatal acrylic, and that puts the point of force application very close to the center of resistance of the lateral segments, so you get more bodily movement. And I found this design to be much more effective at achieving bodily movement than other designs. Now, what are some uses of rapid maxillary expansion? Well, crossbite correction is the main indication. Oftentimes we have poor axial inclination of posterior teeth, and we can use the RPE to improve that. Spontaneous correction of class 2 problems. I'll show you McNamara's approach. Mobilization of maxillary sutures. So if you're going to use a reverse pull headgear, sometimes, and I think RPEs are routinely used in conjunction with reverse pull headgears because the sutures get loose and therefore movement is maximized and made more efficient. Reduction of nasal resistance, which is something that was not proven until recently, but it is proven now that rapid palatal expansion can improve a patient's ability to breathe through his or her nose. And broadening the smile, getting rid of the dark triangles on the corners of the smile. So crossbite correction is the most common use of RPE. It's a stable correction and helps gain maxillary arch length. So a case like this, simple use of an RPE can correct the crossbite. Axial inclination, oftentimes we get molars that look like this. Occlusal forces combined with a narrow skeletal area. And so we can expand to widen the maxilla, which will help idealize the position of molar and premolar roots. And we can use fixed appliances to upright the molars, maybe a heavy rectangular wire with expanded wire, proper arch width. And so we end up with a flatter curve of Wilson, which is better for occlusion. Suture mobilization, we loosen the sutures. It makes class 3 effective correction with face mask therapy much more effective. And most clinicians, if you do any amount of face mask therapies, expand with an RPE and split the sutures before using a face mask. Reducing nasal resistance, it increases the area of the airway. And we can tip the scale and turn mouth breathers into nose breathers as a result of this. And so structural and functional stability, the airway, facial, and oral component. This is Dr. Larry Wolford is a great person to listen to. If you ever get a chance to hear him, he talks about airway and the mechanics of improving airways, and he is a very, very good lecturer. So airway-resistant breathing in growing patients may result in maladaptive craniofacial changes, high proportion of malocclusions. Adenotonsil hypertrophy can make things worse, and the position of the mandible and size can be affected by these problems. And so a combination of tonsillectomy and adenoidectomy and rapid maxillary expansion, the studies are showing that combination therapy provides the best outcome. Broadening the smile, you can see the negative space, the buccal corridors in this patient. And these are very unesthetic smiles. By doing rapid palatal expansion, we broaden that and reduce those buccal corridors, giving the patient a much more aesthetic smile. So maxillary reaction to expansion, not only is it widened laterally, but A-point advances too. So we get development in all 3 planes of space, in the AP plane as well as the lateral plane of space. So you can see that's what happens. Alveolar bending, again, that improves your airway, and there's studies that show that this happens. Mandible swings down, rotates back, increase vertical dimension. Now, if you don't want the vertical dimension to increase, you can use a bonded RPE, and the bite block effect will help reduce bite opening. And expansion success rate with an RPE in the right age patient is about 100%. It works all the time. So in early treatment cases, the upper arch often needs skeletal development, and the appliance, the RPE, is the best way to achieve that development in both the lateral and the AP direction. Let's show a little case here. Danielle at age 6. I thought we were going to need to use a face mask on her because of this class 3 anterior crossbite. So we propped her bite open with a bonded RPE, and lo and behold, we got spontaneous correction of the anterior crossbite due to development in the AP plane of space. So sometimes spontaneous development occurs. We get increase in A point, and if it's enough, sometimes it can really change a bad situation into a very good one. So this became a very routine case. Now, McNamara's approach to class 2 treatment, phase 1 in the 3rd or 4th grade, relieve lower crowding, up to 8 millimeters, lower expansion appliance. Over 8 millimeters, we'll consider advancing incisors. We're going to talk about advancing incisors in addition to expansion in just a few minutes. And he uses a bonded RPE, expand to an intramolar width of 33 to 36 millimeters, add incisor brackets to align the anteriors and retain the upper expansion, poly with a bite plane if the bite was deep, and allow 2 years for lower jaw growth and repositioning. And most patients will shift into class 1. We idealize maxillary shape and the mandible will fit to it. If it doesn't occur, then we can use our class 2 correction protocols for adolescent patients, which is not a topic that we're going to discuss tonight, but this is useful in mild to moderate class 2 situation. If you get severe class 2 problems, it requires a more aggressive approach, probably some sort of repositioning appliance. So let's look at Andrew at age 9. I'm sure we've all seen cases like this. Notice he has a right side crossbite. It's actually a bilateral crossbite with a functional shift. His mandible is shifted slightly to his right. So we started off, he didn't have any lower arch crowding, so we didn't have anything to do on the lower arch, but we used a bonded RPE and expanded him to an ideal upper intermolar width. And after RPE removal, it looked like this. And you can see before the RPE, we had a crossbite. After the RPE, the crossbite was gone. And after the RPE, you can see the molar relationship has shifted to class 1. The mandible spontaneously repositioned after it was unlocked. Now, in cases where we have severe lower arch crowding or narrow lower arches, we need to do lower arch development as well. And that can be done with a couple of appliances. My 2 favorites are the E-Arch and the Williams appliance. I think a very important measurement to see if lower arch development is needed in kids is the intercanine width. Measurement from mesial surface to mesial surface of mandibular primary canines has been a very reliable predictor of crowding in the mandibular and permanent incisors. This is a measurement that is championed by Dr. Lenny Carapezza, who is a Boston, actually Wayland, Massachusetts pedodontist and probably the father of early treatment. And he swears by this measurement. Intercanine width of less than 16 millimeters places the patient in high risk for anterior crowding. So we can use a couple of things. The Williams appliance is a nice appliance to use. And in very early treatment, notice we band to the Ds. That increases the stability of the appliance because the span of wire is not so great. We also use extensions lingual to the 6s, so they participate in the expansion. And this has a piece of 014 nitinol coming out of tubes in the anterior. And as expansion occurs, the niti wire slides anteriorly to help align the 4 incisors. Now, what you have to do is you have to make sure that that niti wire is not going to ride up and over the lingual of the lower incisors. So we just bond a button of composite on a couple of the lower incisors, just incisal to where the wire rests, and that prevents it from riding up and out. And as expansion occurs, then the expansion is directed in the direction that we want it to be, and we get lower crowding relief. So this is an example of how a Williams appliance works. And you would think that the location of the expansion screw would be very uncomfortable for the patient, but it is not. Patients tolerate this really well. It's kind of amazing to me, but I've never had a patient complain about a Williams appliance, never. And here's one showing on a typodont. There's activation of the screw. And this is a very effective appliance for lower anterior development. Another effective appliance is the E-Arch, and there's a nice article. It's article number 4 in the packet, available on the Renstrom.com website, talking about the nuances of using a E-Arch. Where patient compliance is a bit of a concern, this is a self-limiting appliance, and no adjustment by the patient or parent is needed. It's just a compressed coil spring, which uncompresses, thus resulting in expansion. It produces a gentle force. We use the niti coil spring, Keep it in place until full eruption of the lower incisors have occurred. Early phase treatment, and we start early mixed dentition with adequate or excess pre-treatment arch width so the arches develop. And when we start moving teeth around, we have space in which to do that. And we can use them on the maxillary as well, but I use them mainly on the mandibular arch. There's an E-arch. And you can have these ordered with IPC attachments where you can ratchet the attachment to reactivate the screw or the coil spring, excuse me, if you want, depending on the amount of expansion you need. And the lab will work with you regarding whether that is necessary or not, or if one activation will be enough. And this is what the appliance can do. So after the arches are developed, our fixed phase can begin. And that's where I mainly want to talk about the brunt of our meeting tonight. It's going to be on fixed appliance therapy. And we're going to use a 2x4 setup, which means the 2 molars and the 4 incisors are bracketed. And there's a couple of things that need to be discussed about bracketing and initial aligning. There are 2 basic considerations that you have to follow in all early treatment cases. One, switch for lateral incisor brackets, and we're going to bend back the nitinol wires during initial aligning. So let's talk about each of these items individually. The manufacturers of pre-adjusted appliance build distal root tip into all the brackets. Andrew's second key of occlusion indicates that the mesial portion of the crown of the tooth, the crown of the tooth is mesial to the root of the tooth in all cases. It varies from tooth to tooth. Distal root tip is present in all ideal occlusions. Now, this is great for permanent dentitions, but it's not so good for a mixed dentition. And why is that? Well, if we distal tip this root, you can see what could possibly happen. If the lateral root is distally tipped, it could move the root right into the path of the erupting canine. So in a case like this, if we put the lateral brackets on conventionally, we're going to encourage distal root tip. And we don't want that because we could bump those lateral roots right into the crown of the canine and cause root resorption of the lateral, or the canine could slide behind the lateral and become palatally impacted. So we want this kind of setup. This is an ideal early treatment 2x4 setup. How can that be accomplished? Well, if we angle the root in the opposite direction, that is what is accomplished. So during the mixed dentition phase, during treatment, we want mesial root angulation, not distal root angulation. And we're going to do this by switching the lateral incisor brackets. Put the left lateral incisor on the right lateral incisor bracket on the left lateral. And I did do this routinely in all mixed dentition cases. We switch the brackets. That changes the tip. It encourages mesial root tip, not distal root tip. So if lateral brackets are not switched, things may turn out okay, and that happens quite often. But the lateral root could be tipped in front of the erupting canine, leading to canine palatal impaction. Or worse than that, the lateral root may be tipped into the erupting canine crown, leading to possible lateral root resorption. So 3 possible things can happen, and 2 of them are bad. I don't like those odds. I prefer to keep those lateral roots out of the way until the canines are erupting, then switch the brackets back and get the ideal tip that's going to be required to finish the case with optimal aesthetics. So Ben at age 10, and I showed you this this pan just a little bit ago. This was a perfect example of a case where we want to tip those lateral roots mesially. He was an open bite tendency and needed expansion, so he used a bonded expander. And so as we align the teeth, we're encouraging mesial root tip of the lateral. And you can see the position of the bracket especially on the upper left lateral in this picture. The dot is to the mesiogingival, and that bracket is on. That's a right lateral bracket, but it's on the left lateral. And we continue to do that until the canines erupt. And you can see we still have that. And once the canines erupt, we switch them back. and we have avoided potential problems with the lateral root. Now, we're going to do a lot of 2x4 treatment and bypass primary teeth. Now, a lot of doctors like to bracket primary teeth, and we're going to go talk about the advantages and disadvantages in situations where we would bracket primary teeth. But in a lot of cases, we're going to skip the primary teeth and just have a 2x4 setup. Now, when you start initial aligning in this setup, you've got a light nitinol wire, and you've got that flexible wire passing a long span of teeth that they're not attached to. So if that wire becomes deflected or gets deflected by occlusal forces or whatever, it can easily become dislodged from the molar tubes. And when does that happen? By definition, it happens Friday night at 10 o'clock. And your parent will call you in a panic. The kid's wire came out and it needs to be fixed right now because it's poking him. And of course, the kid can't stand the wire poking him. So we want to prevent this from happening. So we bend back the wires distal to the last bracketed tooth. And so we discourage the dislodgement of the light flexible nitinol wire. So the procedure is when we do an initial tie-in and we're doing initial aligning with a light nitinol wire, we insert the wire passively through the molar tubes, don't engage anything, and cut the wire so it's a ½ inch too long. Now we've got to get this wire to be able to be heated or to be able to be bent, and to do that, if you heat the nitinol wire, the spot that you heated becomes work hardened and it can be bent. So we take the end of the wire, the last ½ inch, go to our Bunsen burner and heat the end of the wire until it's red hot. It takes about 2 seconds. And after the wire cools, the previously heated portion is now able to be bent. Tie the wire in, and you've got a ½ inch of wire sticking out distal to the last molar tube. And that wire has been previously heated, so it's able to be bent. And we just bend the excess wire distal to the molar tubes towards the gingival. And then if that's in the way, we can cut it so it's only about a ½ inch too long. We want it to be a ½ inch too long while we're bending it because it's so much easier to bend. And there are pliers that kink nitinol wire. You could use that, but I found that heating it and bending it with either a light wire plier such as a bird beak or jarraback, or even an amalgam plugger, is a lot easier to do. So this is a typical early treatment setup with a 2x4 setup. And if you can see on the picture on the right, the lower arch, the lower, that would be the left side because it's a mirror shot, but it's on the bottom right-hand corner of your screen. You can see that wire is bent back, and that's going to prevent dislodging of the tube, of the wire from the tube. And here's a typical 2x4 setup doing initial aligning. Now, many clinicians prefer to bracket primary teeth as a way of developing arches. And there's advantages and disadvantages to this approach. I'm not really advocating one or the other. It depends upon the situation. But 2x4 bypassing primary teeth enables the clinician to use off-center bends for bite opening and class 2 correction. That is the biggest advantage. And we're going to talk about tip backs and toe ends and why they work and why they are so darn effective in mixed dentition cases. And you can solve a lot of problems and intercept a lot of problems before things get worse. We also get arch development, as you'll see, with passive expansion, which is called the Frankel effect. And I am a big believer in passive expansion. And we'll go into the details of how that works and why it's called the Frankel effect and why a 2x4, when we bypass primary teeth, is effective in allowing or encouraging passive expansion. Bracketing primary teeth, one of the advantages, the brackets don't come out of the molar tubes as often because there's not a long span of wire. And we're going to use shorter coil springs. Maybe the canine or the laterals are blocked out, so the coil spring might only go from the central incisor to the canine. And so your arch length gain's a bit more efficient. One question is bond strength to primary teeth. It's a little tougher to bond to primary teeth. And Dr. Ganji's primer that we gave out, article number 3, really also has a little article on how to bond the primary teeth, some of the changes you should make in your bonding technique, and so you can achieve good bond strength. More initial aligning protocols. If you're going to use a 2x4 setup, you want to get your teeth aligned, your incisors aligned as quickly as possible. And so sometimes managing the primary canines is a way to do that. The concept is I will extract primary canines often in early treatment cases, but I do it to make alignment of permanent incisors proceed more quickly. You can create space so the incisors will align. But we're gonna, if we do that, then we've got to gain the arch length back because the initial aligning is going to happen by the incisors moving back into the spot previously occupied by the canines, and you're going to lose arch length. But we're going to then pack coil to gain that arch length back and advance the upper anterior teeth. So I never extract primary canines in patients under 10 unless I'm placing brackets and managing space. If only a small amount of space is needed to align anteriors, we shave 2 millimeters off the mesial surface of the primary canines to gain that space, and that's an alternative to extraction. Let me show you an example. But before we talk about the example, just the concept, the flexibility of nitinol wires is great. And so the most emergency visits occur during the initial aligning stages. We can decrease the time spent in initial aligning or spent in nitinol wire, we greatly improve treatment efficiency. So that's the reason why we manage the primary canines. So result of primary canines without managing arch length. So just extracting canines and letting the incisors align results in a loss of arch length. You can see that's happened here. This is bad. We don't want to do this. So if we do this in addition to bracketing and then start advancing the teeth with coil spring and getting some expansion via passive expansion, then we can develop the arches and the loss of space is only transient. So in this case, what's the best way to handle initial aligning? Well, in the upper arch, if we extract the primary canines and use a 2x4 setup, incisor alignment will be much easier with the C's gone. And after aligning, we're going to regain the arch length by packing coil between the lateral incisor and the molar in both quadrants. As an alternative, this might be a good case to you to bracket primary teeth because you could just align the incisors and bracket the canines in first and second primary molars, and then pack coil between the central incisor and the canine to create space for the lateral, so you could save the hassle of extraction of primary canines. And I might consider that if I didn't have to use tip backs or toe ends to manage bite depth or class 2. So that's one of the reasons this might be a good case in which to use to bracket primary teeth. So we could extract the upper canines and the lower arch in this case. There's no need to extract the canines because we've got a reasonable amount of space. We're a little short. We can speed up the aligning of the lateral incisors by shaving a bit off of the primary canines and then regaining that arch length with coil. But the lower anteriors can be aligned pretty easily without removing the primary canines. So on the lower arch, shave the canines. On the upper, either extract and use a 2x4, which is what I do most often, or bracket the primary teeth and create space for the laterals by packing coil between the central incisor and C on both sides. Now, in this case, I would consider lower primary canine extraction because it will make aligning the incisors much easier, and we're looking at ease of alignment. Now, managing anterior crossbite. Occlusal interferences often prevent crossbite correction during the initial aligning. So to relieve that interference, we often prop the bite open by bonding composite to the lower E. So this is if there's a lateral in crossbite, say, for instance. And we bond enough composite so the anterior teeth can slide out of crossbite without encountering any interferences. And as soon as the crossbite is corrected, remove the composite off the ease, and overbite will retain crossbite correction. So the general procedure is like a lateral and crossbite in combination with a deep bite is to align the teeth, create space for the lateral, then prop the bite open, then engage the lateral, let it jump the bite, then remove the composite that you prop the bite open with so overbite retains crossbite correction. So after initial aligning is complete, we do an arch length gain procedure. And we usually do this in 016 stainless steel wire. That wire is a little stiffer so it doesn't dislodge as easily, so bend backs are not necessary. We pack coil between the 2 and 6, between the lateral and canine, in any quadrant that is short of arch length. We make that coil 4 millimeters longer than the distance between the distal of the bracket on the 2 on the lateral and the mesial of the bracket on the 6 on the first molar. Now, different quadrants will have different requirements, but we use 4 millimeter longer coils each month until sufficient arch length is attained. So I'm going to show you a typodont. I'm going to switch gears here and go to the Elmo. And I'm going to show you a typodont in which we have a 2x4 setup with coil pack. So bear with me just a second. See if I can do this here. It worked in practice. And here's a 2x4 setup with some coil springs in place. Now, on the right side, you can see the arch wire is tied in, and the coil spring is slightly bowed. And you want this slight bowing because that pushes the cheek out of the way and upsets the muscular balance and allows for arch development due to passive expansion or the Frankel effect. And like I say, we'll talk about that in just a few minutes. But this advances incisors, and it also encourages lateral development because of the passive expansion. And I never underestimate the ability of passive expansion. It really works. And that's why I like using the 2x4 with coil. Now, if we look at the left side, you can see this one is not engaged yet. And that's about the excess length that we want to use, about 4 millimeters longer than the distance between the adjacent brackets. And so we would just kind of compress this and tie this wire in, and that would be engaged. But that's about the width of the coil that we use. It produces a nice forward movement of the anterior teeth without overly high levels of force. So that's your setup for arch length gain. And we gain arch length by advancing the anterior teeth. And we're going to go into the rationale of why the heck we advance teeth, as well as lateral development. So we get both effects as a result of the coil spring. So again, pack coil between the 2 and the 6 in any quadrant that is short of arch length. Coil is 4 millimeters longer. And our goal is to get 22 millimeters of space between the 2 and 6 in each quadrant. And that's the average size of a canine and 2 premolars, 7, 7, and 8. So gaining arch length, combination of expansion and advancing incisors. Now, advancing incisors is much more efficient in the gaining of arch length than expansion. So we're going to call labial movement advancement, lateral movement expansion. So for every millimeter of advancement, we gain 2 millimeters of arch length, and that's just pure geometry. For lateral expansion, for every millimeter we expand, we only get 3/4 of a millimeter of arch length. So we use coil spring to encourage both incisor advancement and expansion. And the expansion is passive and due to the Frankel effect. Here is a setup where the coil springs are used to advance teeth. This is what it looks like from the occlusal view. And once we advance teeth, And you can see that the nice development of the lower arch and upper arch is happening because the coil springs do a beautiful job of keeping the cheeks out of the way, which allow for passive expansion. Now, all faces flatten with age. So when doing an early phase 1 treatment, we want to end with a face that appears slightly full. And that means leaving the incisors position slightly forward to what may be considered ideal. And the patient will grow into this tooth position. So all faces flatten as they mature. I'm just going to show you a couple of pictures of kids 7 years apart. The mechanics of flattening differ in forward and backward rotating patients. In strong muscle patients, the chin grows forward and facial musculature prevent the teeth and alveolar process from following the chin. This is a patient that I treated non-extraction at age 9, what she looked like at age 17. So you can see that she was a little full at age 9, but at age 17, she was actually had a retrusive profile. And so we'd have liked to have kept her even a little fuller at age 9 because faces flatten with age. In weak muscle patients, faces flatten, but the protocol or the reasons why they flatten are a little different. The chin grows down and back, and the retrusive pogonion leads to a flat face. This was a non-extraction case treated 7 years apart. You can see how her face flattened. So we want to keep the incisors a little farther forward than maybe considered ideal, just because the faces are going to naturally flatten with age. Plus, something else to think about, society's definition of beauty has changed. A full face is much more desirable compared to the mid-20th century ideals. So this is a patient I came across that had ideal Steiner numbers, upper 1 to NA of 4, lower 1 to NB of 4, pogonion to NB of 4. And this was the old definition of beauty. When Steiner did his cephalometric analysis and used his niece as the sample size of 1, this is what she looked like, just like this. But we have an old and a new definition of beauty and a new definition of ideal. So the definition of ideal facial balance has changed over the years. And now society prefers fuller faces, which means advancing incisors more. So because of how patients grow and develop, compared with society's new definition of beauty, advancing incisors to gain arch length is appropriate in many early treatment cases. Another advantage using coils, let's talk about the Frankel effect. The Frankel effect is named after Dr. Ralph Frankel, who was an East German orthodontist who practiced immediately after World War II and designed the Frankel appliance, which used face shields, tissue shields, soft tissue shields to encourage arch development in specific places. And so arch development by passive expansion is often called the Frankel effect. And so with coils, most of this effect is in the canine and premolar area. And you can see how those coil springs are going to keep the cheeks out of the way, thus allowing for the canine and premolar area to develop. So passive expansion refers to blocking of the labial and buccal musculature, minimizing their influence on the teeth. This results in widening of the dental arches. So use of coil spring allows for passive expansion as well as development of the arches in the AP plane of space. The expansion is not produced via biomechanical force, but rather intrinsic forces. And the Frankel is an example. So tongue, teeth, and cheeks are at rest in a neutral position. There are no abnormal forces. We change that, we can allow for dental development. There's a lip bumper that works via passive expansion. So advancing teeth with coil in a 2x4 setup gives you active advancing of the teeth, and it gives you passive expansion. So it's a good way to develop arches, especially if the arches are developed almost optimally by a previous use of an expander. Now, early treatment mechanics, tip back bends. After we've gained arch length, we can now get the bite open. And we do that by using tip back bends, and we change the conditions with how the tip back bends are used to encourage bite opening in a specific way. And I'll get into that in just a minute. That is detailed in article number 5 by Dr. Mulligan on the Renstrom website. So I think you should read this article. You'll have to read it a couple of times to really understand what Dr. Mulligan is trying to say, but it's a great introduction to off-center bends. So these are tip back bends on an 016 stainless steel wire. Upper and lower, you can see the tip backs in both arches and the lateral views. But that encourages bite opening. We get an extrusive force on the molars and an intrusive force on the incisors. So our intrusion setup is a 2x4 setup. Now, a tip back bend has to be off center. There has to be a long and a short segment for it to work. And if you engage say the second primary molar and then try to place a tip back between the second primary molar and the first molar, that becomes a center bend, and it is not off center, so you don't get the differential forces. So we need the 2x4 setup. We're going to make tip backs mesial to molars. I'll show you how to do these in just a minute. 016 stainless steel, when you put a 45-degree bend in, if you let the wire sit passively into the vestibule, it's going to provide about 100 grams of force, which is optimal force for intrusion, we think. But there are some considerations when you think about opening bites. How do you want to open the bite? Should the bite be opened by molar extrusion or anterior intrusion? And how do you know which of these are appropriate? And how do you set up the mechanics to favor one over the other? Well, it can be done by using tip backs and manipulating the situation, the environment around the tip backs. So, molar extrusion or anterior intrusion? That's the first question you have to answer. Do you want to open the bite by extruding the molars or intruding the anteriors? So we're going to evaluate lower anterior face height and gingival display. If the lower anterior face height is deficient, bite opening with molar extrusion is indicated because that's going to increase lower anterior face height. Erupting molars increases lower anterior face height. If gingival display is excessive, it indicates the need for incisor intrusion. So this is what we look at, and the patient in the lower left corner of the screen has a low lower anterior face height. So we would need some amount of molar extrusion to open the bite. So here's our anterior face height measurements. 50-50, 1/3, 2/3. We're going to mainly look at lower anterior face height, particularly top tip of lower lip to chin. Tip backs with no modification to the setup affect lower anterior face height less than other methods of bite opening. So tip backs are going to, with no modifications, are not going to erupt molars. They're going to intrude anteriors because the force that you apply to the anterior teeth is about 100 grams. That means you've got 100 grams applied to the two molars because the forces have to balance. And your muscle strength, I don't know what it is, but it's a lot stronger than 100 grams, so the muscle strength will prevent molar extrusion, and intrusion will predominate. If we want to increase molars, there are some modifications to the technique. We want to extrude molars, and molar eruption increases lower anterior face height. Now, the next thing we're going to look at is gingival display. And opinions of what is ideal varies. This is the art of orthodontics. Everyone has a little different view. My opinion is the male smile line. When a young man smiles, I want to see a complete view of the incisors with no gingiva showing. For a more feminine smile, I think it should be a little more gummy, maybe a 1 to 2 millimeters of gingival display. So a female smile line shows more gingiva compared to the male smile line. You may agree or disagree with this, but this is my opinion, and it's the art of orthodontics. There's the ideal smile lines in my mind. The patient on the left is the ideal feminine smile line. The patient on the right is the ideal masculine smile line. Gingival display decreases with age. Therefore, in early treatment cases and phase 1 with 1 to 2 millimeters of excessive gingival display. Don't over-intrude. You age the smile prematurely.
Okay, we're going to demonstrate the bending of a wire with a tweed loop plier, and you can see what the tweed loop plier looks like. If I want to make a tip back bend pointing down, I just have the curved portion of the plier facing up. and simply just squeeze on the wire, and you get your 45-degree, in this case, tip back bend. I'll do this on the other side of the wire to make it even, and that wire is bent at a 45-degree angle. Now, in a patient, we do this right inside the mouth after the wire is tied in. So the procedure is to tie the wire in first. And on Josh here, we're going to open his bite by using a tip back bend. His wire is tied in and it's straight. And after the wire is tied in, we simply place the loop plier in the mouth, squeeze, and the tip back bend is made. Do that on the other side. Josh, if you turn towards your left, please. And place the plier in the mouth, curved end up, squeeze, and the tip back bend is made. So the tip backs are put in intraorally after the wire is tied in. It's a very easy procedure, very quick. And notice that Josh has anterior teeth bracketed and posterior teeth. So we have a long segment and a short segment of the wire. And this will allow for differential torque and differential moments and differential forces, thus allowing for bite opening.
So the off-center bend rule: when the short segment of a wire is placed into the bracket first, the long segment will point in the direction of the force produced at the opposite bracket. So when the tip back is placed and it looks like this, we're going to get intrusion of the canine and extrusion of the molar. The force is on those. Exactly the opposite if the long segment is placed first. Now you look at these two pictures, it's the same wire, it's just inserted differently, so you're looking at it from a different view. The short segment points opposite to the direction of force produced at that bracket. So it's pointing down, that's the short segment, so that's going to be a force to erupt the molar in exactly the same way that this is going to be a force to erupt the molar. So the net effect of the off-center bend is extrusion and distalization of the short segment tooth, usually the molar, intrusion of the long segment, usually the incisor. Since most patients who need intrusion mechanics are strong muscle patients, the extrusive component is usually not expressed, so they get more incisor intrusion. And there's our setup again. Molar extrusion, muscle strength usually prevents it. Now we also get some anterior teeth flaring. Whenever you put an intrusive force on a tooth, the side effect of that is flaring. And this is one of the things you have to be aware of when you are doing a tip back setup with a 2x4. The greater the distance between the point of force application and the tooth center of resistance, the more flaring that will occur. So the rule is flared teeth tend to flare more. And upright teeth tend to flare less. Since most teeth that have deep bites are upright, we want the flaring. We have to be careful when the tooth is already flared. And we'll talk about that in just a minute. So the basic methodology in bite opening and mixed dentition cases, use a tip back with a 2x4. The results in extrusive force on the molars and an intrusive force on the incisors. And the setup results mostly in incisor intrusion because the strong musculature limits molar extrusion. If molar extrusion is desired, we relieve the occlusion. We prop the bite open by bonding composite to the ease, and that takes the molars out of occlusion. When the molars are out of occlusion, they're not affected by the strong musculature, so the molar eruption is encouraged. There's no muscle strength preventing eruption because they're out of occlusion. So the bite opening methodology has changed from predominantly anterior intrusion to predominantly molar extrusion, and we'll show you examples of that. Anterior teeth flaring. This is one thing we have to remember, and the big thing is flared teeth tend to flare more. The amount of flaring increases by a power of 9. It's a cube root formula, and I don't care what the formula is, but point is flared teeth tend to flare more as the point of force application moves away from the center of resistance. So flared teeth tend to flare more. And you can see intuitively how that would happen. Most deep bites have teeth that are upright, so excess flaring is not a problem. In the rare cases where intrusion is needed, caution must be exercised. And basically, we use a base arch and an intrusion overlay, and we'll talk about this at another time. It's more advanced mechanics and done more on permanent teeth. And in most cases, flaring is desired, so we tie the arch wire directly into the slot. So let's take a minute and show you how to do a tip back bend. And we'll get the Elmo set up again. Okay, the first thing that you have to do is you have to understand how the tweed loop former works. So here's an arch wire. You find the tweed loop former. And here's what a tweed loop former looks like. And we squeeze the wire in between the jaws of the plier, and we're going to get a 45-degree bend. Now, when you make a tip back bend, the wire's got to be parallel to the plier. So we don't want it like this, where the wire and plier are not parallel. We want it like this, where the wire is straight. So we don't want it like this. I don't know if that shows up real well, but we do want it like this, where the wire is straight. So we just get the wire straight to the plier and squeeze. And we get a 45-degree bend. Do it on the other side.
Jim, we're unable to see the bend right now.
And squeeze. Can you see it now?
Yes, we can.
Okay, that was my bad. But that's what a tip back bend looks like. Now in the mouth, we usually tie the wire in and do it in the mouth, and we just simply take the plier and squeeze. I don't have this tied in, but that's a tip back, and you can see and the wire came out of the slot here, but you can see the wire sits into the vestibule. Now, as we lift it up and engage it, it's going to provide an intrusive force on those incisors. So the wire sits like this, and as we lift it up, it's engaged and we get the intrusive force. So let's show you a couple of cases. Here's an intrusion case where flaring is desired. Note his gingival display, which is excessive, and lower anterior face height, which is normal or excessive. So what we want to do is we want to open the bite predominantly by intruding the upper anterior teeth. So molar eruption is not desirable in this case, but intrusion is. So our ideal for boys, complete view of incisors with no gingiva showing. He's excessive. So upper incisor intrusion is necessary. Don't prop the bite open. Let the patient's muscle strength inhibit molar eruption. For bites 10 millimeters. Strong muscle patient. Initial aligning, we use the utility arch. We could have easily used a straight 2x4. It's the same thing. Note the bracket position is towards the incisal. And we use differential bracket positioning. One of the reasons why is because the more incisal you put the upper anterior brackets, the more there's expression of labial crown torque. And this is desired in deep bite cases because the incisors are usually upright in these deep bite cases. So the bracket positioning concept is to increase torque by incisal bracket positioning. Because the facial surface of the upper anterior teeth are curved, incisal bracket positioning changes slot inclination. And deep bites are associated with upright incisors usually, so additional torque is needed. So here we go, tip backs on top. We want mostly upper intrusion, so we started on the upper a little bit first, And we started aligning the lower with a 2x4 and a straight wire. And we eventually got the tip backs in all 4 quadrants. And look at his gingival display. 18 months later, after we get the bite open, let the permanent teeth erupt, we get this. So a nice result. I would use a Hawley retainer with a bite plane in this case, because we want, deep bites are retention nightmares, and we want to make sure that this doesn't relapse. Now, Jen is another case where her upper anteriors need to be intruded. Her lower anterior face height is high, so we don't want any molar extrusion. So virtually all of the bite opening should be a result of upper anterior intrusion. So excessive lower anterior face height, excessive gingival display, upper incisor intrusion. So we just did a lower full arch and an upper 2x4 with tip backs. And we let the tip back sit in for about 6 months and let the intrusion really work. After that, after the bite was open, do a full aligning of the upper and lower arch. And here's what she looks like post-treatment. That was major league upper incisor intrusion. Now, Alex, at 9 years old, has a slight deep bite. And if you look at his, a slight amount of crowding, you look at his lower anterior face height, it is a bit deficient. I think this case needs a little molar eruption. So gingival display is pretty much ideal. So to increase lower anterior face height, we're going to encourage molar eruption by propping the bite open by bonding composite to the eaves. And because the molars are out of occlusion, the tip backs will encourage their eruption. So that will change how the tip backs work to encourage molar eruption, and you'll get a little bit of increase in lower anterior face height as the bite opens. So that is tip backs, and tip backs are very valuable in a 2x4 setup. They work great. It's really easy to open the bite in a mixed dentition rather than waiting for the permanent dentition to come in. You've got all sorts of problems with bite opening in permanent dentition. You can open in the mixed, retain with a Hawley retainer while the permanent teeth are coming in, and then do your phase 2. Now you can also do some class 2 correction, and that can be done with toe-ins. And the mechanics of toe-ins, what they do is they're going to expand and distally rotate upper molars. And I think expansion and distal rotation of upper molars is the biggest, most important thing necessary for class 2 correction. And article number 6 on the Renstrom website gives the rationale behind using toe-ins. So the concept is we're going to expand and distally rotate the upper molar. And that is done with a toe-in an off-center situation. We'll show you that in just a minute. The parallel cusp of the upper first molar is positioned more anteriorly as that tooth is rotated to the distal. For optimal occlusion, that parallel cusp rests in the central fossa of the lower first molar. And when that cusp is positioned anteriorly, the lower first molar, and in essence, the whole mandible, has to position itself more forward to occlude. And so the upper arch is a little wider, the parallel cusp is a little farther forward. This is sort of a poor man's repositioning device. So our takeaway from this is if you draw a line from the distal buccal through the parallel cusp of the upper first molar, that line should pass through the opposite canine. If it doesn't, that molar needs distal rotation. So molar derotation is one of the most effective ways to achieve class 2 correction. And the great majority of class 2 occlusions present with mesially rotated upper sixes. So here's a toe-in bend in a 2x4 setup. And you can see the molars are expanding and distally rotating. That's going to encourage class 2 correction. So when diagnosing a class 2 occlusion, always look at the upper arch from the occlusal view. and determine if molar rotation is needed by drawing the line from the distal buccal through the palatal cusp. For optimal occlusion, that line must pass through the opposite canine. Another advantage of distal molar rotation is a correctly rotated molar takes up less space, and so therefore you gain some arch length. Now, if you look directly from in front of the patient, have them smile widely, the widest portion of the arch should be the medial buccal cusp of the upper first molar. So if the molar is correctly distally rotated, that cusp, the medial buccal cusp, is very prominent. Distal molar rotation places the cusp in a more anterior position, occludes at the lower six, so optimal distal rotation of the upper six encourages anterior mandibular repositioning. This is how a carrier appliance, the motion appliance, works. It distally rotates the molars. Here's a slide showing incorrectly rotated molars, more correctly rotated. Incorrectly, look at the lines, correctly. Again, properly rotated molar takes up less arch length. So derotation methodology, mesial bracket placement, the transpalatal arch is often used, and we use a toe-in bend with a premolar or primary molar bypass. That's the brunt of our discussion tonight. Incorrectly rotated molars. The line passes through the opposite premolars. This is contributing to the class 2 molar relationship. Now they're aligned and molars are correctly rotated, and the molar relationship is class 1. That's the picture you want to remember. Now, if we use a toe-in close to the molar, remember the short segment points if the long segment is engaged, which it is here, and we're bypassing, so if there's a long and short segment, the short segment points in the opposite direction of the force that the tooth is going to receive. So that points in, it's going to go out, and it's going to distally rotate. So the shaded tooth below is the result of what will happen with the toe-in bend. And this is very useful in the correction of class 2 malocclusions. So here's an expansion and distal rotation case, 4 millimeter class 2 molar relationship. Note on the occlusal view, the molars are mesially rotated. Again, we use the utility arch on the upper to do initial aligning. It could have just as easily been a straight arch wire. Toe-in bends on the upper, arch length gain on the lower. And once we get the molars rotated properly, note the molar relationship. And this kid is now ready for a very simple phase 2. And the class 2 was corrected in the phase 1. Now, tip back bends, when I do tip backs to open the bite, I usually use 016 stainless steel in an 022 slot. Toe ends, the wire, a little heavier wire seems to work better. That's just my personal observation, nothing scientific about it. So I like to use toe ends in 020 stainless steel. And I'm just going to show you a toe in real quick on the Elmo. I'll try to keep the typodont on the screen this time. These are made with a bird beak plier or a light wire plier such as a Jeraback. And we make these outside the mouth. So the plier is perpendicular to the wire again. And we just hold the wire with the plier and bend the wire with my finger. And that's a toe-in bend, a 30-degree toe-in bend. Do it on the other side. Wire perpendicular to plier, see how it's at a right angle? Hold the wire with the plier, bend the wire with the finger. So those are made outside the mouth. And so typically on a typodont, we'll engage the wire passively. Remember, initial aligning is already done. And we'll just mark the wire with some sort of marker. We'll my typodont doesn't get coronavirus because I'm using non-sterile techniques. Then grab the wire on the mark and just make the bend. And that's a 30-degree toe-in bend. That's probably a little more than 30 degrees. We might back it off a little bit. But that's going to expand and distally rotate the molar. We do that on both sides. And we achieve class 2 correction of about 3 to 4 millimeters quite easily with expansion and distal rotation mechanics. It's a great way to start your severe class 2 cases or to finish your moderate class 2 cases. So if upper molar rotation does not achieve full class 2 correction, then we need repositioning. And many appliances are available to encourage mandibular repositioning, twin blocks, whatever. But my favorite in mixed dentitions is the Rickinator. It allows the mandibular reposition as primary teeth exfoliate and permanent teeth are up. In the permanent dentition, if you've heard me lecture before, we really buy into the fixed functional technique where we use a fixed anterior bite plane. But it's tougher to bond these things in kids because there's only 4 teeth that you can use. So we use a Rickinator. So after arch length gain, bite opening, and distal rotation of the upper sixes, if additional class 2 correction is desired, use a Rickinator instead of bonding a bite plane. And there's what a Rickinator looks like. It just has indentations built in. The patient bites forward, and we usually attach a class 2 elastic from the lateral incisor to the lower first molar just to encourage the patient to bite forward. So take a wax or take a bite registration with the patient in an anterior edge-to-edge position, fit bands, and the lab will fabricate one of these for you. And the class 2 elastics just kind of tease the mandible into a more forward position and train it. And so the Kobe hooks can be placed on the laterals for class 2 elastics. And if you don't know what a Kobe hook is, this is a Kobe hook. It's just a steel tie that has a hook on the end. And it can be tied in. When we tie them in, we usually tie them in underneath the arch wire, not over the top, because then if you change the arch wire, you don't have to change the Kobe hook. But you can hook an elastic on that to help hold the mandible forward while it's under the influence of a Rickinator. So that's a repositioning appliance. So that is a Kobayashi or Kobe hook. Any supply company has them. I want to talk about a couple of, we're going to end this discussion with a couple of little troubleshooting techniques. The first is an canted occlusal plane and general treatment consideration. And this can be done in the mixed or permanent dentition. We have to first of all determine if the upper or lower arch is at fault, and the best way to do that is a tongue blade on the occlusal plane. So make sure that it is, if you're going to use this treatment, make sure it's an occlusal plane anomaly, not a soft tissue problem such as an uneven lip lift when smiling. So permanent dentition, level and align, work up to 016 stainless steel. Mixed dentition, after arch length gain procedures are complete, go to 016 stainless steel with a 2x4 setup. Now in this case, it appears as if the lower arch is at fault. It's running downhill from left to right. The most effective way to level a cant is to erupt the first molar on the downhill side of the arch. So in the permanent dentition, we remove the premolar brackets on that side and even out the occlusal plane by propping up the downhill side by bonding composite to the premolars or the primary molar. So we're leveling the cant, but the molar is going to be out of occlusion. Then we encourage eruption of that molar by placing a 45-degree tip back bend immediately medial to the molar. Unilateral tip back, just on one side. Again, that molar is out of occlusion. There's no muscle strength preventing it from erupting because there's no occlusion. When it's fully erupted, remove the composite off the premolars. And discontinue the tip back. Rebracket the premolars and engage the premolars with a continuous arch wire, and they will erupt into occlusion. If both arches are canted, this can be done on both arches simultaneously. In mixed dentition treatment, the same concept of unilateral tip back is used. We even out the occlusal plane by bonding composite to the primary molars on the downhill side. Unilateral tip back, when the molar has erupted into occlusion, we remove the composite off of the primary molars. So that little bit of eruption on unilateral eruption by using a tip back, remember the bend has to be off center. You can't have all the teeth bracketed and have this work. Can really effectively relieve an occlusal plane cant. And these small cants in mixed dentitions tend to worsen. If you can get rid of them during the mixed dentition, you intercept a lot of the problems that could potentially occur later. Open bites, I don't have much earth-shattering to say on open bites. The article that I added to the packet that's available on the Renstrom.com website is very good regarding tips on managing open bites. So that's something you should read. The first thing we look at is diagnosis, skeletal versus dental. High numbers indicate skeletal problems, mandibular plane angle, lower face height, shape of the mandible, muscle strength. And muscle strength in patients with open bites. The angle of the masseter works a little different compared to deep bite patients, so it doesn't discourage eruption. So management of the open bite is basically a fight against weak musculature. The battle is predominantly won with the combination of arch development, myofunctional training, and habit of appliances. So etiology, habits, airway obstruction, genetics. We talked about habits, we talked about airway obstruction. That's the first thing we look at in an early treatment case. Again, the tongue has to be in the right position. And the downward and backward rotation means we're fighting growth a lot of times in these open bite patients. Posterior half of the palatal plane is tipped downward. If you draw a line and do what's called the angle, the maxillary mandibular angle, palatal plane to mandibular plane, that number will be inordinately high. Pharyngeal space is constricted further because of the short ramus. That encourages people to keep their tongue forward. So there are tongue thrusting tendencies that have to be relieved. And if there's tonsils and adenoids in the way, that further increases the propensity for tongue thrusting. And so we see this all the time. Swollen tonsils and adenoids, narrow palate, mouth breathing and low tongue, weak muscles, deviate swallow. So the combination of airway management and myofunctional therapy and probably some habit appliances will make a big difference. Now, most orthodontic open bite treatment fixes the problem by moving teeth. So when a skeletal open bite is present, the dental movement camouflages skeletal discrepancy. That's why dental open bites respond better to orthodontic treatment than do skeletal. So we're going to treat dental open bites and skeletal open bites approximately the same way, but the prognosis is just a lot better for dental open bites. Treatment options, habit appliances, a transpalatal arch and or lingual holding arch, preventing upper molar eruption. Low load deflection rate arch wires, we try to stay away from stainless steel because they don't overpower the masticatory muscles. Remember, all mechanics are extrusive, and heavier high load deflection wires are more extrusive than light low load deflection wires. And the open bite patients often don't have the muscle strength to overpower the eruptive effect of the mechanics. Prevention or eliminating deleterious habits done at a young age, removal of tonsils and adenoids, and allergy management. Anterior box elastics, Kobe hooks in the lateral, mild brace. If you get a good kid that's a cooperator at a young age, you get a family that buys in. Mild brace works very well with open bites, but cooperation is an issue. They're very difficult to wear exactly as prescribed. And it takes a very special child and family to have the dedication to do that. But if they do, man, they work. External anchorage is effective as an adjunct, but we're talking about early treatment and what's the appropriate age to use a TAD. Some of the studies are showing that the bones are not solid enough till a patient is 12 or 13 years old before a TAD can be placed, and that's open to discussion. But remember, if we can limit molar eruption, 1 millimeter of limiting eruption can result in 3 millimeters, or 1 millimeter of molar eruption can result in 3 millimeters of backward rotation. So if we can close the bite by 1 millimeter, we can get 3 millimeters of anterior bite closure. Consequences of non-treatment: poor aesthetics and poor patient image, poor anterior and lateral guidance, unprotected possible posterior teeth, and poor TM joint function. So treatment sequence: airway evaluation and management, habit cessation, arch development. Upper arch development is often necessary due to low tongue position and lack of development that happens as a result of low tongue position. Fixed appliance therapy, arch length gain, molar rotation, class 2 management, and then management of any remaining open bite. ENT specialist, resolve the mouth breathing, a mild brace or some type of oral screen. If you can do that before you start the 2x4 phase, much less open bite management is needed. Bonded RPE, take advantage of the bite block effect that limits vertical dimension increases. All these things can nickel and dime the correction of open bite. They all contribute slightly. And you can use a tip back bend in reverse. Again, you have to bypass the lateral segments. It has to be a 2x4 setup. And if you use a tip forward bend or an upside down tip back, make the bend about half the size as if you would for a regular tip back to open the bite, because of the side effects, the lingual rotation of the incisors that happens as they extrude. You're going to get an increase in gingival display if you use this, but it is very effective. If side effects become severe and you can't get the open bite corrected in the mixed dentition, wait to the permanent dentition. We have much more effective ways of correcting open bites in the permanent dentition than in the mixed. If you get some of it corrected, all the better. But sometimes it's just a permanent dentition problem and a little easier to correct. The last thing I want to talk about real quick is a class 3 case, or anterior crossbites. Bonded RPE unlocks the occlusion and allows for efficient face mask response. We showed you a case earlier where we propped the bite open with a bonded RPE and the anterior crossbite spontaneously corrected. James, when he was 8, did not have such luck. He had a 29 millimeter intermolar width, so he needed arch development, and an anterior crossbite, so he needed development in all 3 planes of space. And you notice when these kids are crowded, their eruption is delayed. He's 8 years old, doesn't have his permanent central incisors in yet. And that's a sign of crowding. Class 3 molar relationship. Here's a bonded RPE. And then we start face mask therapy. And I use this picture all the time because I love the picture of the kid with cross-eyed for a cross bite. And elastics at a 30-degree downward angle. And you can see how the correction proceeded quite easily. Now, my typical instructions for reverse pull headgear: in the house, in the mouth. So that's 12 to 16 hours per day. We try to get them to commit to a 5-month wear schedule. That's probably a lot, but that gives us some overcorrection. So we deliver the RPE and activate for 2 weeks so we get the sutures loosened. Then we deliver the face mask, slightly downward direction of pull of the elastics. Month 1 and 2, 450 grams of force. So it's usually 3 5/16 inch medium per side. A 5/16 inch medium provides 150 grams of force. Sometimes we have the bigger elastics, the 3/4 inch. Sometimes we only need 2 of those, but about 450 grams of force per side for the first 2 months. Month 3 and 4, we go 300 grams of force. We cut down to 2 elastics per side. Month 5, 150 grams of force, 1 elastic per side. Month 6, we take the face mask off and remove the RPE. So we design the whole system so that the RPE comes off at the same time that the face mask is stopped. Because we usually leave our RPE and active expansion for a month and 5 months of just letting it sit passively to allow palatal bone healing. So there's method to my madness. The 5-month wear schedule of the face mask coincides with the length of time that the RPE has to be in, and that leads to treatment efficiency. 30-degree downward direction of force is most effective for advancing the mandible. It does open the bite, but that's part of the deal. And sometimes bite opening is necessary in these class 3 cases because the downward and backward mandibular rotation makes the mandible appear less prominent. For dental class 3s, the last thing I'm going to talk about tonight is the QCK appliance, which I've had very, very good luck with. And this is a picture of the appliance. And this provides a anterior force, a labial force on the incisors. And again, the same thing holds true with this appliance as it does with the Williams. You need to bond a button of composite on each of the incisors, immediately incisal to where the wire rests. And this is pre-activated. It doesn't require any patient cooperation except to keep the thing in. And we can prop the bite open if the bite is deep, and we can get really good bite jumping with this. So a case like this is an ideal case for a QCK. If the skeletal relationship is closer to class 1 than class 3, there's a picture of it in place, and that's the result. Now, relieving occlusal interferences often helps. So we relieve occlusal interferences until the bite is jumped. Then we take off the composite that we prop the bite open with, and overbite retains the crossbite correction. And that's before and after. And I thank you for attending. If you want to email Scott any feedback that you have at Renstrom and give a request for CE credits, when we get an email, we'll send you a CE credit sheet. And thank you for your attention. Have a great night.
Well, thank you very much, Dr. Prittinen. That was awesome. I want to thank everybody for, like Dr. Prittinen said, coming out on a Wednesday night, a beautiful night. Does anybody have any questions? Feel free to, I'll unmute everybody, but if anybody has any questions, feel free to shout out, or you can write over chats, and I can let Dr. Prittinen know what you say. Otherwise, if nobody has any, we'll wait a few minutes here, but if nobody has anything they want to ask in front of everybody, like I said, Dr. Prittinen can be reached at the email that's on your screen right now, if you have anything you'd like to privately ask him.
Thanks so much, Jim. Great presentation.
Thanks, Mark.
Really enjoyed it. Got some good pearls.
Good pearl.
Oh, I also wanted to mention, Dr. Prittinen had written an Introduction to Muscle Strength journal article, and I posted that on the Renstrom webpage as well. So if you go to renstrom.com and go to the education tab under journals, there's an Introduction to Muscle Strength if that would interest anybody as well. Otherwise, just below the journal tab is where all 7 of those orthodontic articles can be found. All right. Well, it doesn't appear to have any questions, Dr. Prittinen. Thank you very much for your time tonight and all your information.
Well, thanks, Scott. I appreciate it, and I appreciate you all attending. If you have any questions or think of any, please feel free to email me. I'll be happy to answer them as best I can.
Sounds great. Thanks, Dr. Prittinen. Have a great night and have a good weekend.
Thank you.